And let's talk about BTK inhibitors in follicular lymphoma. I think they're commonly prescribed, more commonly than you could imagine in the relapse setting in patients with that. That's despite the data, right? Right, Matt? I mean, there's data that suggests that that's really probably not a good thing to do. There's also data that suggests, it's a single-arm study, but in the front line, maybe we're getting different results, although it's hard to interpret.
Right, I think that it's taken one of those wins where this is non-Hodgkin's lymphoma or indolent non-Hodgkin's lymphoma. It's approved in marginal zone, it's approved in Waldenström, it's approved in CLL, SLL. So if it's approved in there, why wouldn't it work in follicular lymphoma? And I think, in the data that has been shown to date, it's not a very effective drug in follicular lymphoma, especially in the patients that are refractory to rituximab. That's where I think the drug has toxicities to it. It has risks, and I don't know that it has necessarily a place in follicular lymphoma, speaking specifically to ibrutinib.
Yeah, and I might just say, I'm going to think about, I've said this now several times, I'm definitely going to be thinking about a PI3 kinase inhibitor way before a BTK inhibitor, just because the activity is much, much greater with the PI3 kinase inhibitor.
I was thinking about a scenario that's going to come up more often now that the AUGMENT trial is positive, and just going back into history and thinking about what happened when idelalisib was combined with lenalidomide. So what is the washout time that's going to be necessary for a patient progressing on lenalidomide that you want to start a PI3 kinase inhibitor? I think it's going to be very interesting to kind of watch that, making sure that there isn't this kind of sepsis-like syndrome that comes out over time. So spacing, but it's a theoretical thing, but one that I don't know we've necessarily encountered, because there probably hadn't been a lot of second-line lenalidomide use in the prior PI3 kinase trials.
It's one of our major flaws of what we do is we don't really understand sequencing because we don't study it.
Right. Yeah,
correct. Yeah, good. Well, we've really had a great discussion today and tackled many different topics. I think I maybe give each of you a couple of minutes here, or a minute or two, to talk about any closing thoughts, any take-home points from today.
I think that I'll take the AUGMENT trial. I think it becomes an option, a very strong option for people who are relapsed post follicular lymphoma in the second line, and I think that's where I'm going to see my use go up.
Yeah, I think AUGMENT is exciting. We talked about relevance. I think that's still exciting too, but a different aspect is to, again, come back to PI3 kinase inhibitors and to really understand that we're just starting to really figure out how to use these drugs. They're not a new class of drugs, but unfortunately, it took us a long time to get where we're at now, where we're starting to look at the idea that we need to be doing this in a perhaps different way. And Matt, you alluded to duvelisib and some alternative scheduled dosing. There's other PI3 kinases that are in development that are looking at intermittent schedules after early cytoreduction to try and avoid late T cell or T regulatory cell dysregulation and subsequent immune-mediated adverse events. So I think we're going to hear a lot more about PI3 kinase inhibitors, and not just hear about them, but understand how to use them better so that we will actually give a significant opportunity for our patients to benefit from that class of drugs.
So today it's quite clear the therapeutic scenario for follicular lymphoma. Frontline bendamustine plus rituximab, or you can choose bendamustine plus obinutuzumab according to the guidance study, but we discussed it before concerning the toxicity. Second line R-square for sure, R-square because it's active, it's less toxic, and you can also apply for aggressive follicular lymphoma because there are several interesting data concerning that. And for that third line, we have PI3K inhibitors, several PI3K inhibitors. And I totally agree with Topagel because we need more data concerning the possibility to increase the activity and at the same time to reduce the toxicity of PI3K inhibitor, including an induction treatment with a regular dose and then for 3-4 months, and then to use a low dose like a maintenance consolidation treatment for 6 months, 1 year. So to increase the efficacy and reducing the potential toxicity.
Yeah, we didn't get a chance to talk about it, but there was an abstract from the MEI drug looking at a PI3 kinase inhibitor, looking at alternative schedules on this approach, and it seems really promising. I take home from this discussion that we're I think for the first time in a long time, we're starting to get a more sort of a unified approach to the treatment of follicular lymphoma. Well, thank you for your contributions to this discussion. And on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.